I just think magic. Okay, thanks everyone. Thanks for inviting me to speak about my research program. So I don't have any disclosures other than the fact I do research in cardio-oncology as well as imaging, specifically cardiac MRI. So today we're going to focus mainly on the cardiac MRI related work. And so I actually had the opportunity to travel to Newfoundland. I'd never been to that before, to that province, and beautiful part of the country. Many hiking trails you can do there. And in terms of the title for my talk, in research, I find often research takes you directions you weren't always expecting. And sometimes you try to control the narrative or the direction things are going, but in my experience, a better approach is just to sort of follow the road. You don't try to tell the road where to take you. You just follow the road, and that's often when you find the most exciting outcomes, in my experience. But yeah, I recommend if you need any advice about where to go hiking in Newfoundland, I have a couple of recommendations for you. Okay, so I'm going to start with a case to sort of illustrate some of the things we're going to be talking about. So this is a 60-year-old man who comes to the emergency department with palpitations. He's medical history of hypertension. In terms of family history, as a son, a daughter, a brother, two sisters are all alive and well. He's got a father who's died of lung cancer, a mother who had a history of coronary artery bypass. And on ECG, this is for Daryl. He was in atrial fibrillation. I'm not going to show the ECG because I didn't have enough time, but his rapid AFib, ventricular rate 140. He got cardioverted in ER. His heart rate was 53 after cardioversion. His ECG, Daryl showed sinus rhythm with a short PR, what was thought to be a delta wave, like a funny little inflection. And then intraventricular conduction delay, LVH on the ECG. And his labs were notable for proteinuria and a little bit of renal dysfunction. Okay, and unfortunately, I don't think this is going to play, but I promise you, I think all my other videos are going to play. So his echo showed concentric LV remodeling, so thickening of the heart. And the septum measured 13 millimeters. There was biatrial enlargement. And then he ended up getting an MRI as well, just because there was a concern about hypertrophied ventricle and why is his ventricle hypertrophied when his blood pressure appears to be well controlled. So he got an MRI. Okay, so these are called our cine imaging. So you can see his 4-chamber and 3-chamber view. His ventricle looks a little bit thick. Upper limits of normal would be 12, so 13. And his mass was also kind of upper limits of normal as well. Then we did something called T1 mapping, which gives us some insight into the myocardium. He had a low T1 for his heart. So normal T1 is 940 to 1,040, so low T1. And then we measured his extracellular volume. Extracellular volume fraction for him was normal. Okay. Then we did our late gadolinium enhancement imaging, which is the imaging we do to look for scar. And you can see that there's some gadolinium uptake in the basal infralateral wall. So you see that on the 3-chamber and on the short axis. So on the short axis, if you look at 3 o'clock, you can see there's some white in the myocardium there. So by now, I know you all probably know the diagnosis. No, not all of you, but so what would be the diagnosis for the case? So is this simply a case of hypertensive heart disease? Is this a case of hypertrophic cardiomyopathy? Is this a case of cardiac amyloid, Fabry's disease, or Danon disease? Anyone want to make a guess on this one? I gave some clues with the ECG down. So this is that's true. That's a good point. Good point. All right. Yeah. So this is a tricky one. So some of the imaging fellows, some of the more senior ones might know this. But Edgar, do you know what this is? Fabry disease. Yeah. Very good. So it's a classic case of Fabry disease. Yeah. So So it's an X-linked. Actually, I'll show you. So Fabry disease is a sex-linked lysosomal storage disease where patients have a deficiency of alpha galactosidase A enzyme, and that leads to an accumulation of these lipid-like molecules called glycosphingolipids in their lysosomes. And so these lysosomes get packed full of these molecules, which eventually lead to damage into the cell and then the organ itself. So it affects the heart, it can affect the kidneys. So it affects men more severely than women, but it also affects women as well. So it's an important disease to recognize because there is also a treatment for this. There's an enzyme they could give people. So there's enzyme replacement therapy. Okay, so back to the talk. So I'm going to give, because we're talking about imaging research today, I'm going to talk a little bit first, though, about our clinical program, CMR program at our institute, and then talk about some areas of application in heart failure and cardiomyopathy, a little bit like the case I just showed you. Okay, so this gives you some numbers, some stats for our imaging program at the Heart Institute. This is our clinical volumes, and you can see I've highlighted the MRI volumes there for you. So those are largely cardiac cases. Anyone want to guess? Actually, Daryl said when I arrived. Anyone want to guess when I arrived? So I arrived there when we went from 1,700 to 3,000. So I'm not going to claim credit for that, but but it has led to some challenges. We've essentially doubled our volume from what we were doing 6 years ago. Okay. And in terms of what we do when we get our requisitions, well, this gives you a breakdown of sort of the referral question for when people are referred to us. What are they asking us to look for? So you can see that 82% of the referrals that we get, there's some question that relates to cardiomyopathy. So that could be, dilated is very common, myocarditis, hypertrophic, amyloid. So those comprise the bulk of our referrals to our CMR program. So why is it so popular? Well, I've just showed you one example, but there are in fact several examples of where MRI has been used to image various types of cardiomyopathy. This is taken from the ESC 2023 guidelines. So when I talk about cardiomyopathy, these are a group of myocardial diseases that lead to heart failure, but can also lead to arrhythmia and risk of sudden death. Okay, so they're very important diseases to recognize. And they can be broken down by phenotypes. So you can see there's hypertrophic phenotype, dilated, and now there's this new phenotype, non-dilated LV cardiomyopathy, arrhythmogenic cardiomyopathy, and then restrictive cardiomyopathy. So these are the different, and you can see these are examples of MRI being used to help in each case. Okay, and then we are doing some research on the magnet. Daryl was asking me if we could image the left atrium. So we do a little bit of research. So our numbers have grown. I don't have the latest fiscal year, but we're doing on average, I would say 3 to 5 a week now, research cases. But obviously the clinical demand puts some strain on what we're able to do research-wise, but we do have some research program, and I'll talk to you about some of the research we're doing on our clinical magnet. And then I was also asked to say a word about our core lab. So we've just sort of relaunched our cardiac imaging core lab called Circle. We're very happy to have a new manager in place, Ashley Asquith, who brings a ton of experience from the cath lab, has done a lot of clinical and research work in the cath lab related to imaging. And so we've just finalized our business plan with help from research service offices. And so we're supporting actually 37 projects right now. People don't realize how busy we are in the Circle Core Lab, but we have 37 projects we support. So we're very active core lab. And if you have questions, these are the types of services we offer listed on the slide. If you have questions about it, you can reach out to Ashley or myself. Happy to tell you more about the core lab. Okay, now switching back to the talk. So why are we doing CMR, or why even bother doing CMR in cardiology? While we get very detailed information on cardiac structure and function, but really the thing that sets cardiac MRI apart from all the other imaging modalities is we get very detailed information about the tissue, about myocardial tissue. And a lot of that information we get is, you can get a lot of information even without giving contrast. So it's a very safe modality. It's now been proven safe to do in people with implantable devices like pacemakers, defibrillators. The problems we run into in those patients deal more with image quality rather than safety. So we still haven't conquered that issue for some patients. It's now safe to give gadolinium contrast with the newer agents that we have to people with low GFR. And I would say there's increasing availability across the world for this modality. Okay, now I have one slide about physics. And if you have more physics questions, you have to ask Becca. I don't know where she went. She's still here. Oh, there you are. Okay. So Dr. Thornhill will take your physics questions if I can't answer them. But basically, the MRI is a big magnet that aligns protons in one direction or the anti-direction. And hydrogen is the most abundant source of protons in the body. So largely what we're imaging in our case is hydrogen. And then the most abundant source of hydrogen in the body is water and fat. So we're doing a lot of sort of water fat type imaging. And the way we get our signal is we induced radio wave signals into the body, into whatever we're imaging. And that causes excitement of the spinning protons. And when we turn off the radio waves, the protons revert back to their normal direction. And then they release energy, radio wave energy, back to some receivers, and we get our signal. And depending if it's fat or water, that causes different signals that we receive and produces very high contrast images. And so a typical protocol for us when we're imaging is we're imaging cardiac function, structure, but then the main thing, like I said, is the tissue. We want to get information about the myocardial tissue. So there largely are three main techniques that I'll be talking about today. So we do something called late gadolinium enhancement imaging. We do myocardial T1 and ECV. Those things tend to go together. And then we do myocardial T2. And I'll tell you more about those in a moment. Okay, so this is what a typical sort of function image looks like for us. So we get, as you can see, quite detailed information about the left ventricle, the right ventricle. We trace very clearly the endocardial border, the epicardial border. And you can see that we have very good reproducibility for our numbers in terms of EF between different readers. So it really helps being able to say, has there been a significant change in EF over time? If you're following people, you can see here, they're getting absolute differences in sort of the 2 to 3% range, which is a very good confidence interval. Okay, and then the contrast that we give is a gadolinium-based contrast. So gadolinium is an interesting metal. It's a liquid metal that sort of goes into the extracellular space. So it does not get into cells unless the cell membrane is disrupted. That would be the only way it gets into a cell. So here you can see, gadolinium, there's a picture of it getting into the extracellular space. And if there is, if the cells have died from an infarct or some other process, well, then there's more extracellular space for these molecules to get into. And that causes T1 shortening. So it affects our T1 properties. And depending on the type of imaging we do, like late gadolinium enhancement imaging, we get more a signal coming from the myocardium. So we're better able to detect injury or infarction or infiltration, things that affect ECV is when we would use gadolinium. And so here's some examples of patterns. So depending on the disease type that we see different patterns for gadolinium enhancement. So you can see there's several different non-ischemic patterns. So we can tell if someone has more of an inflammatory cardiomyopathy, infiltrative cardiomyopathy, hypertrophic, genetic. And then sometimes we have a pattern that we just call non-specific, it doesn't really correspond to any pattern of cardiomyopathy. We can get ischemic patterns, which are more endocardial pattern or transmural, and then we can have mixed patterns. Sometimes people have both. ischemic and non-ischemic going on in the same heart. And then this is an example of a study where they were looked at patients with reduced ejection fraction, and they looked what was the pattern of scar that they found when they did the MRI, and what was the status of the coronary arteries. And you can see they sort of lumped them into four groups. So there was one group of patients who had no scar, but had coronary disease. There was another group that had coronary disease plus ischemic cardiomyopathy. So that's the second row. The third row, coronary disease and a non-ischemic scar pattern. And then the last was coronary disease with dual scar pattern. So both ischemic and non-ischemic. And the interesting thing, when they mapped survival or events on these patients, you can see the ones that had the highest rate of events or the worst survival were the ones with the CAD plus non-ischemic cardiomyopathy or CAD with dual cardiomyopathy. So it is valuable to predict, events depending on the scar pattern. In this case, surprisingly, it was the non-ischemic scar pattern plus the presence of coronary disease that led to worse outcomes. And then we are doing a study with Michel Lemay. He got some funding through CIHR recently, where we're looking more in depth at infarct-related scar, and that actually is the primary outcome of his study. So he's giving an SGLT2 inhibitor, dapagliflozin, to patients as soon as they come in with their STEMI. And we're measuring infarct size at 3 to 5 days, with the hypothesis being that SGLT2 inhibitor will reduce infarct size compared to placebo, compared to no SGLT2 inhibitor. And then we have a bunch of secondary outcomes we're measuring as well, where we can measure area at risk. And then I've shown you an example of microvascular obstruction. So you can see within the infarct, there's an area of dark, which you can see by some of the yellow arrows there. They're pointing at sort of a dark core within the center of the infarct. And we know people with microvascular obstruction have worse outcomes. They have more remodeling, more ventricular events. And then on the left is something called T2 star, which we can use to look for hemorrhage as well. We can measure myocardial hemorrhage using T2 star. So bad things. You don't want to have microvascular obstruction or a hemorrhage. So I think we're about a third of the way or a quarter of the way into his recruitment for that study. So stay tuned. We should have data within the next 2 years, I would say. Okay, so that's a little bit about late gadolinium enhancement. I'm going to talk about T1 now. So T1 is a mapping technique that we use on the myocardium to detect a number of diseases. Basically, we're looking for myocardial fibrosis or myocardial infiltration. So I showed you an example earlier of a case with Fabry's disease, where because fat accumulates in the muscle, that lowers the T1 value of the muscle, and they end up with very low T1. It's because Fabry's is an intracellular disease. It actually does not affect, or it doesn't affect ECV. So that's why the ECV was normal in that case. Most other diseases like amyloid, that's a true extracellular disease. So T1 goes way up in amyloid, as does ECV. And then there's some data here I've shown you in the bottom right. You can see ECV is also being used to predict outcomes for patients with ATTR cardiac amyloidosis. And in fact, I'm using it. So I work in cardiac amyloidosis clinic. I use it for some of the patients that I follow. I'll get like a annual ECV for me to get a sense, are they responding to the therapies? They receive very expensive therapies to try to modulate or modify their disease. And we want to know, are these therapies working or not? If I see the ECV going way up and their cardiac function dropping, well, that's a clue that maybe the therapy is not working like we hope it would. Okay, so this is some work I'm doing with one of the fellows who recently finished our program. And so what we're realizing is amyloid is being detected at earlier and earlier stages. I think people are getting better at thinking about amyloid more than they used to 5 or 10 years ago. And so we're seeing patients coming for a scan with very, very early signs of the disease. And initially, it was very hard for us to recognize. We were like, this looks almost normal to me. And so what we decided to do was we decided to better phenotype how this low burden or early amyloid actually looks like. So we've compared, we gathered up 83 patients over the last 3 years of patients who had come through our clinical program. And we compared patients with low burden disease, which we defined as an ECV 28 to 43%. Moderate burden disease was 43 to 56, and high burden 56 to 73. And you can see that as you progress from left to right, there's more and more GAD uptake in the ventricle. And then I think even Daryl, you'll appreciate the left atrium has a ton of GAD as well on the bottom right. Do you see the gadolinium uptake? No. I hope so. Okay. You used to do it? On rats, okay. Well, this is all human data that I'm showing you today. But yeah, so there's a ton of uptake in the ventricle as well as in the atria. And this is pathognomonic for amyloidosis. But it's really these early stage disease. You can see we really only have gadolinium uptake in the basal infralateral wall. And we don't really appreciate, so only in the basal segments. And don't really appreciate much going on in the left atrium there. Interestingly, though, in patients who had low burden disease, they had very clear survival advantage over the patients who had more higher burden disease. And this is important because the therapies that have now been developed for ATTR cardiac amyloidosis, they work better in early stage disease. We know that if you give it to them at late stage disease, often it's too late. Okay, so we really want to detect these patients early. Then we also said, are there things that can help us distinguish early stage amyloid from, let's say, early stage hypertrophic cardiomyopathy? Because these are two conditions where patients have thick hearts. And so we did find that the extent of LGE as well as the global ECV were both very predictive in predicting, do they have amyloid versus hypertensive heart disease or mild HCM. So potentially helpful there. But then going a little bit further, we sort of asked her, one of the limitations of cardiac MRI and amyloid is we cannot distinguish ATTR subtype, which is a subtype where the defect is in the liver. The liver is making a mutated form of a molecule called transthyretin that turns into amyloid, versus AL or light chain subtype, where the amyloid is coming from the bone marrow due to mutation in the bone marrow. So we cannot distinguish between those two. All we can say on MRI is, yes, there's amyloid. We cannot say it's one versus the other. So we asked ourselves the question, is there more information that we can glean from looking at these images or analyzing these images? And the answer is, well, with the help of Dr. Thornhill, we've been using a process called radiomics, where it's an image analysis technique where it allows extraction of information that is not really visible to the naked eye. So it can discern things, different features within the pixel. So we actually look on a pixel by pixel basis. It can give information about texture, about spatial orientation, about shape, signal intensity. So there are things within the pixel, information, patterns within the pixel that we cannot see, that radiomics, this image analysis technique, allows us to see and gives us information that we can then put into models for improving our diagnosis as well as our clinical risk prediction as well. And so we applied it to a group of patients who came for MRI, and we asked ourselves the question, if we just use our traditional LGE, ECV, how good are we at distinguishing ATTR versus AL? And you can see the dashed line here on the receiver operated curve. We're better than a coin flip, but not that much better. But then when we use radiomics, that really enhances our ability to discern beyond what we would be able to say just from the traditional markers on CMR, and we ended up with an area under the curve of 0.88. So pretty good for a first step, like better than normal that we're able to say. We still have some work to do, but it's something that I find an encouraging area. Okay, so now, so that was T1. So reminder, T1, you're mostly looking at extracellular space, scar infiltration. T2 is a technique that we use to look for myocardial edema. So we're really looking at water content within the myocardium. And we use that to look for myocarditis. We use that for acute MI. So in the DAPA-STEMI trial, we were helping to understand the area at risk or how much inflammation there is. We've used it for transplant rejection as well. And this is an example of somebody who's come in with acute heart failure and was found to have myocarditis, where the T2 is very elevated, 68 compared to normal, which is usually less than 59. And so it can be used for, getting back to the topic of cardiomyopathy, we use it for a condition called Takotsubo cardiomyopathy, which is so-called broken heart syndrome, or stress-induced cardiomyopathy. And this is a case we had not that long ago that we published. And the classic appearance of the Takotsubo is there's something called apical ballooning, where the left ventricle apex, is dyskinetic. It's really not moving very well. And in this case, I'm showing you there is no apical ballooning. There is, if you look very closely though, in the lateral wall, the mid-lateral wall, you can see that there's an area that looks a little bit hypokinetic or akinetic, but otherwise it looks like a very normal ventricle. You're not buying that, Darren? Okay. So anyway, I'll have to take my word for that. When we did the T2 and T1 mapping though, it tells a different tale. So you can see that the T2 is elevated just like you would expect with Takotsubo. The whole apex is elevated. So if you look on our bullseye plot, these are all abnormal values greater than 57. So you can see the whole apex is lighting up, as are many of the midventricular. So even though you can't see the wall motion abnormality, the tissue mapping is telling you a different story. And that's sort of the power, again, of cardiac MRI versus some of the other imaging modalities, like echo, for example, not to pick on another imaging modality. But, okay, so, but can we do more? And so, so now there's an increasing recognition that Takotsubo is not as benign a condition as we once thought it was. If you follow these patients, they actually do have adverse events, both cardiovascular, cardiac, as well as cerebral. And so one of our fellows, Yoshido Kadoya, he's done some work that's just been accepted as an abstract at SCMR, and we're about to submit this manuscript, where he's shown that the T2 global T2 measurement at when these patients come for their scan, it does actually it is somewhat predictive of their outcome. And you can see here he even did some adjusted modeling where he used a bunch of clinical variables, age, atrial fibrillation showed up in the model there, Daryl, you'll be happy. So that one actually was predictive of outcome. But so was T2. T2 was also predictive of outcome, along with neurologic trigger as a cause for the Takotsubo. So it looks like, so this would be the first study showing that T2, an MRI measure, can potentially be used to triage patients who are more at risk for adverse outcomes. Okay, so I've talked to you a lot about the heart and how we can use MRI to image the heart, but it still doesn't help us oftentimes understand about the patient's symptoms and about their exercise intolerance. And one of the core features of patients with heart failure and cardiomyopathy syndromes is they have exercise intolerance. And in fact, peak VO2 is also a very, very strong, one of our strongest predictors of survival. And there's increasing recognition now. Yes, the heart plays a large role in people's understanding people's exercise intolerance, but there are many other factors that influence people's exercise intolerance. And in fact, in HFpEF in particular, there are likely many extracardiac factors involved in terms of skeletal muscle quality is one big factor. So the ability of the skeletal muscle to extract oxygen delivered to it from the blood, and then reduced pulmonary reserve is another big factor probably as well. And so MRI is very good, not just for imaging the heart, it's actually good for imaging all organs. We can get the same sort of tissue mapping that we do in the heart, we can do in the lungs and the kidneys and the skeletal muscle and all the organs. And so we've done some work trying to use the similar techniques in the lung to get an idea about pulmonary edema. And so this is some work I did with a biomedical engineer out west, Richard Thompson. And we developed a sequence where we were able to quantify the amount of lung water. So how much pulmonary edema does a patient actually have? You know, rather than X-ray, looking at X-ray saying, well, he's got some pulmonary edema, but this is actually putting a number on it. So we were able to say, you know, it looks like this lung is 20% or 30% full of fluid. Okay, and we got a pretty good correlation with filling pressures when we mapped people. We did the MRI and then brought them down to the cath lab, and we got a pretty good correlation with filling pressures as well. And then we measured this in a larger group of patients with heart failure. And you can see as you move through the NYHA classes, the median lung water goes up. So these are patients with ambulatory heart failure. And then it also was a good predictor of events. So people who had dry lungs versus wet lungs. So if someone had a lung water density less than 20.8, it had much lower event rates than people who had lung water densities greater than 20.8. And then even when we did modeling with adjusting even for things like BNP, lung water still was an independent predictor for outcome for these patients. Okay, so now we have some funding from CHR where we're studying the same technique in patients with acute heart failure. And one of the questions we're asking ourselves, how good are our inpatient therapies to reduce the amount of lung water for people in the hospital? So you can see this box plot on the left, I've box plot of patients' lung water density of people when they first come in and we do an MRI versus when they're discharged. And you can see on average, the lung water density goes down by roughly 10%. Okay, so which is interesting because to my knowledge, no one has tried to evaluate how much, you know, we don't really have a good technique for assessing diuresis for patients in hospital. We look at their JVP, we measure their weights, but we don't really have a sense of what the impact of therapies are on fluid in the lung. So this is sort of the first study to sort of give us some insight into that, to my knowledge. Okay, so we talked about heart, we've talked about lung, and now I'm also going to talk about skeletal muscle. And so this is some work done by Mark Hakowski, who actually came and gave these rounds in January. So Mark is an exercise physiologist. He is actually a nursing background, but he's done a lot of work with a fellow, Delene Kitzman at Wake Forest, where they've looked at patients with HFpEF to understand, you know, why are patients with HFpEF out of breath? Like, what is the main mechanism for their exercise intolerance? And so they did some imaging work where they imaged their skeletal muscle, the thigh muscle. And then they also looked at their peak VO2, and they found that there was actually a pretty good correlation between the amount of fat infiltration in skeletal muscle, inverse relation, and peak VO2. So the more thigh muscle fat you had, the worse off your exercise tolerance was. Okay, so, and it was actually in many of their work, it was the strongest predictor for exercise tolerance was the skeletal muscle, not the heart. And then we've done some similar work in long COVID. We were trying to understand what are the factors predicting just how symptomatic these patients are. And it turns out one of the best ways to predict symptom burden in long COVID is to do 6-minute walk. There's a very good correlation between 6-minute walk and symptom burden. And we found similar things to what this previous slide I just showed you, where one of the best predictors of 6-minute walk was myosteatosis. Is there fat in the skeletal muscle? And you can see here an R value, we were getting an R value of 0.5, which is, you know, not too bad between myosteatosis and long COVID. And it correlated pretty well with the 6-minute walk. We even found a reasonable correlation in our healthy patients, although not quite as tight as we found in the long COVID as well. So you know, muscle quality is a good predictor of exercise tolerance. And then we did some modeling to say, okay, in all of the variables that we have in long COVID, all the clinical variables, all the circulating biomarkers, and all the imaging, what are the best predictors for symptom burden? And the best predictors were actually female sex, which would agree with the rest of the literature. So females have higher or more severe symptoms than males with long COVID. And skeletal muscle fat fraction was actually the second most common thing to appear in our modeling, a variable along with BMI and a few other factors. You can see lung actually didn't appear anywhere. It was mostly skeletal muscle and then BMI and so body composition along with a little bit of cardiac there. Okay, and so the way I interpret this is, you know, there's a lot of chronic diseases, so HFpEF, long COVID, cancer survivors, we're recognizing that they all have very similar phenotypes. They're all groups of patients with poor exercise tolerance, and they all have abnormal body composition. That's what we're learning from doing these studies. And skeletal muscle definitely seems to play a role. Now, the question I know Daryl's going to ask me, okay, what do we do with that information? So how do we treat myostatosis? And the short answer is I don't know. But what I'm going to try is an SGLT2 inhibitor. So there is some data showing that SGLT2 inhibitors reduce ectopic fat pools, specifically visceral fat. So not in the skeletal muscle. No one's actually looked at that. But it does reduce, these are imaging studies showing that it reduces visceral fat. And so we propose to do an RCT for giving dapagliflozin to patients with long COVID, thinking that because of our observations in the study I showed you a few slides ago, we think it's going to help with their symptom burden, help with their physical activity, with their 6-minute walk. So we've got a little bit of funding from CIHR and long COVID to start this RCT, where we're going to see if we can improve their symptom burdens as measured by EQ5D, which is a patient questionnaire, a quality of life questionnaire. So stay tuned. We may have some answers about that. Okay, so that's how we use, that's all the potential advantages of MRI to help phenotype patients with heart failure or chronic syndromes like heart failure. And, you know, so you can see why it would be popular, why we're getting so many referrals for cardiomyopathy. The other reason we're getting a lot of referrals is the guidelines. So you can see the American guidelines. These are the 2022 AHA-ACC guidelines. They give a 2A recommendation to use CMR to image patients with heart failure. And then the European guidelines went one step further. They came out a year later and they've given a class 1 recommendation. So they say, yep, you should be doing, it says CMR, contrast-enhanced CMR is recommended in patients with cardiomyopathy at initial presentation. So all patients, so they're recommending it for every single one with a cardiomyopathy, come for CMR. I'd love to say that's great. The problem is it's playing havoc with our wait times. So you can see that our wait times are growing. Rob, you probably don't want me to show this, but what's that? Yeah. So our wait times are growing. So we need to be, you know, I would say strategic in how we're approaching all of these referrals coming for cardiomyopathy. You know, we've got tons and tons of referrals, which is a great problem to have. But then I think it behooves us to ask the question, you know, are they appropriate? So we did a study with under the direction of Dr. Beelans at the back called the Outsmart Heart Failure Study, so IMAGE-HF study, where we tried to answer that question, you know, could we be a little bit more selective in who we do our CMRs on? Now, this is not cardiomyopathy. These are patients with non-ischemic heart failure. So not quite the same population, but close. And we wanted to compare a strategy of doing routine CMR on everybody versus being more selective and only doing it on people who we thought it was likely to make a difference, like hypertrophic, infiltrative. And we looked at the rate, okay, can we actually detect a new heart failure diagnosis by the CMR? Okay, and then we compared, these are the two groups at baseline. You can see that there were a lot of patients who ended up in the study who had dilated phenotype. They were the majority of patients. And then the more interesting cases like the inflammatory or restrictive or infiltrative, they comprised less than 10% of the patients in our study. Okay, so that's important, I think, to note. And so most of the patients I would tell you had what I would consider a non-specific etiology. So what I mean by that, these are patients where there are no targeted therapies beyond GDMT. So patients like run-of-the-mill dilated cardiomyopathies, tachy-induced cardiomyopathy. So there isn't really any specific therapies for these patients, and they form the majority of our cohort, unfortunately. And so perhaps not surprisingly, when we looked at our primary outcome, there was no difference at 3 months or 12 months, and in fact, there was a trend to having more specific new diagnoses in the selective group over the routine group. So there wasn't really an advantage from what we could tell to doing routine CMR on all patients with non-ischemic cardiomyopathy. Now, there are some important limitations of this study. Number one, like I said, it wasn't a non-ischemic cardiomyopathy population, so we didn't have the patients coming to assess for arrhythmia like ARVC, PVCs, which are a common reason for referring patients for CMR. And we did this study before the era of tissue mapping. So we didn't have, all we had was LGE. We didn't have T1 or T2 mapping. So, so that definitely was a limitation of the study. Nevertheless, I still have questions about how useful MRI is for doing it on all patients. So we've looked back, or started to look back at the cases that we've done here at the Heart Institute to see, how often do we actually make a difference in finding a new diagnosis or a new finding that was unexpected on the CMR. And so we've broken it down sort of into two groups of referrals. So patients are referred to us assessed for cardiomyopathy, or they're referred to us for, this patient has PVCs or VT. Is there an underlying cardiomyopathy? And you can see that when the question is a phenotype of hypertrophic, inflammatory, infiltrative, while our yield of finding a new diagnosis or new information that'll impact care is pretty high, it's around 50%, versus a dilated phenotype or someone who just has a non-specific LV dysfunction, our yield rate is much lower. It's about 7%. Similarly, if patients have ventricular arrhythmias, if they have what I would term a high risk, so if they have VT, VF, out-of-hospital cardiac arrest, high-risk genotype, our yield is very high, 44%. If it's someone just coming with PVCs or non-sustained VT, our yield was much lower, 10%. And you could argue, some of these things I've written down there, you could argue just how much are they actually going to make a difference in their care, but I was trying to be as generous as I can. So at the end of the day, what this means is there's potentially 33% of patients who would fall under this sort of lower yield category. So if that would have a massive impact, if we could reduce our case volumes by 33% and only focus on the higher yield cases. So we're now conducting a more in-depth retrospective review of our scans to see, to confirm these initial findings based on our preliminary review. And I've also submitted a grant proposal to CIHR to do a cluster RCT with crossover with these specific aims. So in patients with suspected non-ischemic cardiomyopathy, determine if a more selective use of CMR leads to a higher rate of specific cardiomyopathy diagnoses compared to routine use CMR, which is currently what's going on right now. And the primary hypothesis is that we will get a higher rate of specific diagnoses in the selective use over the routine use. And then this is our trial design. So the one thing I'll say, getting back to the title of my talk, the road less traveled. So you can imagine when I pitched this idea to my colleagues doing CMR across the country and told them, listen, we've got to find a way to reduce doing CMR on lower yield scans. Well, not everyone bought into that idea. They're like, what, you're trying to tell me you want to reduce my clinical volumes for CMR? I'm like, yeah, I think we should focus on the patients who actually need the test rather than the patients who don't. And so not everybody bought into this concept. It's a controversial area, but I believe it's the right thing to do. It's the right things for patient care. Okay, so in summary, I hope I've shown you that CMR allows detection of a number of underlying cardiomyopathies, and largely it's through what we call tissue mapping. So that's LGE, T1, T2. And then there's some exciting opportunities right now locally and abroad using more advanced techniques, many of them using machine learning or AI techniques. One of them, I showed you an example, radiomics. And then my research program has a keen interest in extracardiac tissue as well. So to help understand disease burden. So we're looking at the heart, lung, and then we're also looking at body composition, including skeletal muscle. And then I also question whether CMR should be routinely used for all cardiomyopathies. That certainly my experience has not been that it benefits every person with a cardiomyopathy. I think that's an undesirable approach. I think it's an unsustainable, I think it's an irresponsible approach. So that's something I hope to prove in the research that we're doing. And I want to acknowledge there's a ton of people, I'm probably forgetting some, but I've tried not to. So a lot of people here at the Heart Institute have been wonderful to work with. These are current, future collaborators. And then I have a number of trainees as well who are involved. We've got Connor, who's sitting here from the new grad student from the CTM program, which has been great. And I still have a few collaborators at the University of Alberta as well. So with that, I'm happy to take any questions.
Great, Ian. Thanks very much for the presentation. That's wonderful. So just to remind people, if you have a question, please come up to the mic here so that people can hear you offline as well. And if you're online, please use the Q&A feature to submit your questions. I have a question first, Peter. So my biggest problem when I was doing my rats was that they'd wake up in the MRI thing and scamper around and I'd lose my images. Has it gotten faster? Like how fast can you guys do your scans now?
So I guess short answer is yes. So the latest, so the one thing I didn't mention is we're going through the process of getting a second scanner, which will help with our wait times. And so if you sit on a vendor presentation, what they'll try to sell you on is there's more and more AI being incorporated into image acquisition and image post-processing, which means that you don't have to collect as much image data. So a lot of, there's sort of missing data that now gets filled in by AI, and that leads to a quicker scan time. So yes, but I don't think we're certainly never going to be at the point of CT. Like now with the latest photon counting devices, they claim to be able to get the information in one cardiac cycle. So one heartbeat, they get the information. Okay. Yeah. So I don't think we're ever going to be there. We're still in MRI, we're often averaging information over 10 to 12 heartbeats. So yes, things are gradually improving, but I don't think we could image a scampering mouse.
So start to finish, it's what? How?
So right now clinically we're booking patients in 45 to 1 hour time slots, but a scan we could probably drill it down to 30 minutes in most cases if we really had to.
Okay. Yeah, so it's moving along. Yeah.
Yeah.
Peter.
Thanks, Ian, and thanks for all your leadership and work that really has accelerated the program. My question is about the COVID data on the fat density predicting reduced activity or reduced activity tolerance. Like, wouldn't that be true for other patients regardless of COVID?
Absolutely, yeah. No, for sure. And so the slide I showed before, it's the main determinant for activity levels in HFpEF patients as well. So Mark Hakowski has shown that with a fellow named Elaine Kitzman from Wake Forest. More so than cardiac factors or lung factors, the best predictor for activity and VO2 was skeletal muscle. And they've even looked at skeletal muscle oxygen uptake as well. And the main abnormality, that was the main abnormality they found in these patients, that they had abnormal skeletal muscle oxygen uptake. So skeletal muscle VO2 is down in these patients. So you're right, it's not specific, but it's sort of, for me, it's a measure of chronic disease. Like I think you see it, cancer survivors, we see it. So the question is how to target it, right? And
so that was my next question. Yeah, is like, are there things you can intervene upon?
So what we've proposed to do is, we've got some money from CIHR to use an SGLT2 inhibitor, thinking that, this might be, because SGLT2 targets fat pools everywhere, and we're hoping, but I'm sure there's lifestyle things, right, as well. Like it's going to come down to healthy lifestyle choices as well.
Since great, yeah. So thanks again for the fantastic help in terms of all the different protocols that we have, and also some of the functional, sort of measurements in terms of a microvasculature that we're doing as well. Maybe I'll just follow up on the discussion regarding the peripheral muscle, which was my secondary question. So this is one of these so-called sarcopenic obesity, right? So this is actually very well known in terms of high-risk feature for chronic disease. And I think the COVID is really well illustrated. And some of the data suggests that, besides exercise and protein-rich diet, but GLP-1 agents, sort of may actually do that, so I think maybe after the DAPA study, you can actually look at the GLP-1 agent as a opportunity as well.
So,
yeah.
So the yes and no. So the potential concern with GLP-1 agonists is that they can also cause sarcopenia themselves, right? So there's a concern that they can lead. So can SGLT2. I didn't mention that.
Yeah.
But both of these agents, probably GLP-1 agonists more though, can cause, I shouldn't say cause, they've been associated with loss of skeletal muscle volume. Like if you follow these patients over time, there is a risk, and I don't know that, I understand why, maybe but their skeletal muscle volume decreases over time. So yes, maybe you're successful in getting that fat out of their muscle, but now they have lower muscle volume as well.
Yeah, but that could be actually a dose related, and maybe the combo agents, maybe if to
maybe
get around
give them
that.
some testosterone with the
yes, right, yeah. Well, but one agent at a time. Yes, that's right. Yeah. So I guess the practical question, but I do think measuring the muscle is actually very important. We used to do these iron studies, in patients with iron cardiomyopathy, and we actually get to the peripheral muscle data, at the same time. Very, very useful. The question is, in terms of, using gadolinium, and now, there's the mapping procedures and things like that, whether there is a way in which, one can actually, customize, the protocol to the question, being asked. And then the other thing, which I think, come to your discussion, and I absolutely agree that, when you're actually doing these studies, it really should, make sure that the study answers a very, very specific question rather than kind of, throwing MR to the patient and see what sticks, right? that is not, so when we're actually doing diagnostic studies, right, the data has to actually make a difference in terms of decision making, rather than say, let's see, by chance we might pick up something useful. Yeah, so I think, really it should be that way. But, some of the other centers, I found out that through our experience that the MR accessibility and the marketing is very, very different from center to center. We're really, sort of fortunate, right, to have actually MR being dedicated for cardiac, but not every center has that. So, so the answer they give you in the other centers, is full of potential conflicts. So, you don't want to take there at the face value. But I do think that, the study is worthwhile because I think being able to tailor the study, to the question being asked is really actually where the value is for the MR.
I mean, I think this is true of not just CMR, right? Like we should, I mean, there's the whole Choose Wisely program, and there's other programs where we should be judicious with our taxpayer dollars and our healthcare dollars. Like we should be doing tests, whether that be ECG, echo, blood work, unless really it's going to answer a question or advance the care of a patient. And so I'm proposing this in CMR, but I don't think it's unique to CMR. I think it's across the board, right? We should be asking these questions. I know CADITH has, they've proposed it. They've looked into, there could be huge cost savings if we were more judicious in our imaging, for example. So yeah, I believe it's an important question, regardless of whether I alienate some other centers from wanting to work with me on this project. But there's a couple that have agreed though. Now, getting to your question about having a tailored LGE, I mean, I'm not sure I understand, but one comment though I'll make about that is there are techniques now, AI driven, where that are being explored, where you can do a contrast scan without giving contrast. So like where you'll get the information from your T1 map and some AI, and it'll tell you where the scar is. Okay, so people are looking at that. So yeah, we're maybe not too far away one day where we have the needleless exam. We're not giving anyone contrast or needles, which would be wonderful. Like we'd all love to move in that direction. That's, as you know, Matthias is all about that for doing his stress oxygen sensitive imaging as well. So it's needleless exam. There's no needle for the stress, no needle for the contrast, just some breathing maneuvers. So we'd love to be able to do that. Yeah.
Amazing. Well, great. Thank you very much. And what a great talk. Appreciate it.
Thanks.
Yeah.